Hello, my name is Lisa Göschel. I'm working at the Medical University of Vienna, and my specialization is rheumatology. So I'm working in an outpatient clinics, and we are also getting in contact with rare immunological diseases. And it's really a pleasure that I can talk to you. And I think this conference is a unique opportunity to get in contact with other MDs who are treating this very novel, interesting disease. So I want to present a case report about a young African woman to you today. And she was at the age at around 24 years old when I got in contact with her, and when she was first treated at the Medical University of Vienna. And she was suffering from neutropenia in combination with fever and severe oral ulcer. And apart from this, she was complaining about headaches all the time and abdominal pain. And her constitution was quite bad. She had already 3 children, and at this time, at the first presentation, she was pregnant with her 4th child. And because we were not sure about the disease and we had no idea what's going on, we treated her with antibiotics. And this was not really successful. So her constitution was bad over all in all 5 years at our university. And then we tried to treat her with glucocorticoids, so with steroids, and we realized that her constitution was getting better immediately. So we were sure about an autoinflammation disease or autoimmune mediated disease. So we tested her for morbus Behçet, but she didn't suffer from any other signs except this oral ulcer, which are too massive for Behçet and not typical. So we ruled the morbus Behçet out. And of course, we tested her for other autoimmune and rheumatological diseases like lupus, but there were no signs for a classical rheumatological disease. So because she had once positive ANCA antibodies, so anti-neutrophil antibodies, we treated her with rituximab because we thought that the severe neutropenia is an autoantibody mediated neutropenia. But rituximab didn't lead to any changes in her constitution or in her white blood cell count. So we tried different other immunosuppressive treatments over a period of around 4 to 5 years. And after this time, our group had again a closer look at her, and we performed an cell status of the immune system, so an immunological status. And we found it quite interesting that she was lacking T cells, especially CD4 T cells, and that her B cells and NK cells were nearly absent. So at this time, it was about 2018, we already heard about the ADA2 deficiency and this very new disease. And we discussed her case in our immunoboard. So at this time, this is an interdisciplinary board of rheumatologists, of genetic MDs, and it's interdisciplinary, and we are discussing here special cases, very suspect and rare disease which are mediated by immune dysregulations. So this was quite good because my colleagues mentioned that it might be ADA2 deficiency. And at this time, she was under the treatment with cyclosporin A, and her constitution was quite bad. We gave her, she was treated with high dosage of glucocorticoids, of steroids. We couldn't taper them down. So for around 1 year, she got this cyclosporin A treatment, but it was not satisfying, and her headaches and the ulcers, they were really massive. And because of this discussion in the immunoboard, we were thinking about treating her with an anti-TNF treatment, because at this time there were some really new papers where this was the most promising, and it is still the most promising treatment strategy. And immediately after the initiation of anti-TNF, we treated her with infliximab. Her white blood count increases, and it was possible to taper the steroids down to 5 milligrams a day. And it was quite interesting because we couldn't get rid of the steroids in general. So 5 milligram is her threshold, and is still her threshold. She needs prednisolone, but with anti-TNF, we were the first time successful in treatment, and we managed her that there is no flare for more than 1 year. And because we suspected a monogenetic disease, we performed sequencing. And this is her, and this is one of her 4 daughters. And what you can see here is that we identified a novel missense mutation, which is leading to a different amino acid sequence in the ADA2 gene. And it's in the dimerization dimerization domain of the gene, and the dimerization domain is quite important for the activity, for the plasmatic activity of ADA2. This mutation is leading to from glycine to a tryptophan, and at this time when we published her, there were already other patient described which had the same mutation or the same amino acid, the same change in the amino acid sequence, but they had a complete different phenotype. Together with Michael Hirschfield, where we were really happy to collaborate with, we could manage that. We measured the ADA2 plasma activity of the patient, and what you can see here, it was nearly 0. So there was no activity, and somehow we can confirm our suspected disease, the ADA2 deficiency. In her case, it was quite interesting that the treatment and her constitution was quite stable for 1 year. In the last 3 years, we had to switch to 2 other anti-TNF treatments because she got flares again, really heavy flares, which were always dominated by the severe neutropenia followed by infections. So it was not only infliximab, we treated her now with certolizumab, and it's also successful. So her constitution is getting better. There are no symptoms, there are no ulcers, but we don't know if there's a lack of efficacy after 1 year of the treatment, and we hope now that this is really stable and she is fine. The interesting thing is that she has 4 daughters. All of them are heterozygous here. 1 is shown in between. We tested all 4. And one of the daughters, she's now at the age of 14. She develops signs of diseases within the last 3 months. So there's also a heterozygous patient in this family, and we will start to treat her and see if this is also, if we get a treatment response in her daughter. The other 3 daughters are fine. However, the affected one is the oldest one. So we will see what the time brings. In conclusion, we see that this is really that the diversity of the manifestation of this disease is quite difficult to diagnose. And the interdisciplinary board and immunological trained people are absolutely necessary to diagnose rare diseases. And in addition, whenever you have a disease like this, when the experts are sure that there is an immunological mediated disease, but you cannot find a diagnosis, you should consider genetics analysis as soon as possible, not to lose time. And this is the right way to diagnose it. And at this time in Austria or in Vienna, it's faster and it's more used. And so we have already 8 patients with other 2 deficiencies, and we are more routine in treating them and in diagnosing them. Thank you so much.